that we are all here, Dr. Vincent Buttle. Dr. Buttle recently joined our team of spine surgeons in September, and we are super grateful to have him on board. He is a native of Wall Township and completed his undergraduate degree at Monmouth University before moving on to complete his training and residency at Rowan University School of Osteopathic Medicine in Stratford. Following his residency, he completed his fellowship in orthopedic spine surgery at Beaumont Hospital in Royal Oak, Michigan. He specializes in the treatment of spinal disorders, focusing mainly on degenerative conditions, including cervical and lumbar radiculopathy, myelopathy, disc herniations, and spinal stenosis, as well as traumatic injuries to the spine. He is trained to perform all facets of spinal surgeries, from major open surgery to minimally invasive operations. Dr. Buttle also specializes in revision surgery for adjacent segment disease, recurrent stenosis, failure of fusion, or loosening symptomatic hardware. He practices at all 6 of our office locations, so he is easily accessible to you. And without further ado, I'm going to pass the virtual mic over to him.
All right. Thanks, Savannah. I appreciate the introduction, and I appreciate all of you taking time out of your night to come hear me talk. So we're going to be talking about cervical radiculopathy and myelopathy today. So just sort of what Savannah touched on, just a little bit of my background. So as she said, I'm a local guy. I grew up right here in Wall Township, New Jersey. I attended the Academy of Allied Health and Science, then went on to Monmouth University, where I majored in chemistry with a concentration in biochemistry. At Monmouth, I was accepted into their 4-4 program with Rowan University for medical school, where I went to medical school at Rowan's University School of Osteopathic Medicine. I subsequently stayed at Rowan and the New Jersey or Jefferson, New Jersey Health System for my orthopedic surgery residency. And then my 10 years of formal training ended in Michigan at nationally ranked hospital, Beaumont Hospital in Royal Oak. I had an extremely busy fellowship year. I completed over 550 surgeries out in Michigan. It was a great learning experience, and I had the distinct honor of working with and learning from some not only nationally but world-renowned surgeons. So these are our objectives for tonight's talk. So first, we're going to discuss exactly what cervical radiculopathy is, what cervical myelopathy is. We're also going to discuss this diagnosis of quote unquote double crush and what exactly that is. And then while discussing radiculopathy and myelopathy, we're going to go over the signs and symptoms of each, what you as a patient can expect in the office if and when you come and see me, and then how I as the surgeon diagnose radiculopathy or myelopathy. And then lastly, we'll talk about the treatment options, both conservative and surgical options. So when we're talking about cervical radiculopathy and myelopathy, when you look at this center picture, this is a picture of the whole human spine. What we're going to be focusing on is the top 7 vertebrae, which is the cervical spine. So what is cervical radiculopathy? Well, the American Academy of Orthopedic Surgeons defines radiculopathy as a disorder involving a dysfunction of a cervical nerve root that commonly manifests as pain radiating from the neck into a distribution of the affected root. So simply put, that's compression of your nerves in your neck that causes pain, numbness, or weakness going to your arms. So you might be asking yourself, well, why does compression of nerves in my neck cause pain going down my arm? Shouldn't a majority of my pain be in my neck? And the reason is that humans, for the most part, are all wired the same way. We know that specific nerves innervate specific portions of your body and specific muscles. So, for example, if you have compression of your C7 nerve root, that will predictably cause pain going to your middle finger, along with triceps weakness. And similarly, if you had compression of your L5 nerve root, that would cause pain to the top of your foot, as well as weakness with bringing your big toe up. So based on these, what we call dermatomal maps, we're able to correlate imaging to signs and symptoms. And so when we examine a person for cervical radiculopathy, we look at specific areas. So again, without getting into too much detail, if you have compression of your C5 nerve root, that'll cause pain to your upper outer arm, along with some deltoid weakness. C6 will cause pain to your thumb and index finger, along with biceps weakness. I already talked about C7. C8 is will cause pain to your small finger and your ring finger, as well as difficulty with making a fist. And then lastly, your T1 nerve root will cause pain in the upper middle portion of your arm and difficulty with spreading your fingers. So I'm going to jump real quickly to what cervical myelopathy is. And the reason that I'm doing this is because I just want to define what cervical myelopathy is, because the diagnosis and the treatments for radiculopathy and myelopathy are pretty similar. So, everything that we just talked about in terms of defining radiculopathy, we'll keep on the back burner. And then we're going to talk a little bit about myelopathy, and then the two will come together. So, unlike cervical radiculopathy, myelopathy is a little bit more difficult to define. So all patients develop age-related changes in their cervical spine. And this causes what we call cervical spondylosis. Essentially, it's arthritis in your spine. And if you get enough arthritis in your spine through various mechanisms, you can get compression of your spinal cord. And you can see here on this image on the right side, this is an MRI of a patient, and they're having compression of their spinal cord, and we see signal changes on their MRI. Cervical myelopathy is the most common reason for spinal cord impairment in adults. So it's a very common thing that I see as a spine surgeon, and that orthopedic surgeons see across the country, and really across the world. So what makes cervical myelopathy a little bit more difficult is the symptoms are not as clear as radiculopathy. So as I mentioned before, radiculopathy, you have compression of a nerve root, you're going to get pain in a specific distribution. With myelopathy, patients often complain of neck pain, or they'll have more diffuse pain throughout their extremities or diffuse numbness. They'll also, a lot of times, maybe not themselves, but family members who come to the visits with them will say, "Oh, I've noticed a change in the way that they've been walking. They seem to be off balance." And then if I ask the patient to get up and try and, do a heel toe walk, they're often surprised by the fact that they can't do it. Another key finding in cervical myelopathy is people have difficulty with what we call fine motor tasks. So buttoning a shirt, buttoning your pants, holding a cup of coffee, writing. All of these things maybe have become difficult over the last, couple months to a year. And I'm going to discuss the treatment options in a few slides, but the important point with cervical myelopathy is that the symptoms will tend to plateau, and then all of a sudden they'll get worse. And then they'll plateau again, and then they'll get worse and plateau. And no one can really tell you when that plateau is going to stop and when your symptoms are going to get worse. The key being that when you have treatment for cervical myelopathy, the sort of expectation is that you end up where you start. So if you're really having difficulty with fine motor tasks, there's a chance that you get some of your dexterity back after, surgery, and we take the pressure off of your spinal cord, but you may not get that dexterity back, and really the point of the surgery is so that you don't get worse. So again, I mentioned this in sort of our objective slide. So, I want to talk about these two topics. So one is myeloradiculopathy, and the other one is double crush. And I'm not going to go off on too much of a tangent about these two, but myeloradiculopathy is essentially exactly what it sounds like. It's patients who have both myelopathy and radiculopathy. So they have symptoms of difficulty with fine motor tasks, but they also have sharp shooting pain going down their leg. Down their arm. And that's, again, treated very similar, and we're going to get into the treatments in the next couple slides. Double crush is a little bit of a unique diagnosis, and it's something that I always keep in the back of my head whenever I'm seeing a patient. So it's this concept that you can have compression of your spinal cord or your nerves in your neck, but you can also have compression of your nerves throughout your arm, so peripherally. And there's, really three main areas, but it's not limited to these areas where you can have compression. But you can have compression in your brachial plexus. More commonly, you can have it in your cubital tunnel, which would affect your ulnar nerve, or you can have compression of your median nerve, which would be carpal tunnel. So the important thing for me as the physician is to realize if you potentially have a double crush, because if I take the pressure off of the nerves in your neck, you may still have symptoms. You may have to, it may require you to have a second procedure done by one of the hand surgeons or a shoulder elbow surgeon to release the nerve peripherally. And there's different ways to tease that out in a patient's history. So, what exactly kind of causes radiculopathy and myelopathy? Well, the most common cause is going to be a disc herniation. So, the discs are the soft parts that sit between the bones and the spine. If they, it's more common that like the inside of the disc pops out, so the jelly comes out of the donut and it causes compression of the nerve root. These next couple, so disc degeneration, cervical spinalosis, facet arthropathy, loss of normal cervical lordosis, and osteophytes. We can group all of those things into arthritis. So it's arthritis of the spine that ultimately causes compression of the nerves or compression of the spinal cord. And then the last two, while they are possible, they're less common, but more serious if you do have them. You can get compression from tumors and infection. But again, that's a less common cause, and again, that's usually a case by case basis that we see those patients. Um, so what can you expect when you come in the office? So the first thing I'm going to ask you to do is tell me about your symptoms. Where are you feeling pain? Are you feeling pain? Or have you noticed weakness? Have you noticed numbness? Um, what's the character of the pain? Where's the location of the pain? When did it start? Uh, what's the intensity? 0 being no pain, 10 being the worst pain you've ever felt in your entire life. How long has the pain lasted? Has it just not stopped? What makes it feel better? What makes it feel worse? And what things have you done about it? Have you already done formal physical therapy? Have you taken anti-inflammatory medications? Have you had an epidural steroid injection? Things like that. Are you seeing a chiropractor? So those are all important things that I need to know about you, again, to help me come to a diagnosis. And then other important things that I always ask patients to tell me about is, are you on a blood thinner? Do you have significant medical problems? Maybe you have diabetes and it's not well controlled at this point. And another important thing, particularly when we talk about the neck, is letting me know, have you ever had surgery on the front of your neck before? Not just neck surgery, but like uh, surgery on your thyroid is one big example, and because that changes the way that I need to plan for treating you. Um, and then the next thing is I need to examine you. So this is where I test your muscle strength, I test your sensation, and then there's a number of special tests that I do. Again, it's all to help me formulate a proper diagnosis so that I can give you treatment options. Um, Everyone who comes in my office pretty much gets an X-ray. If you don't have one, I need you to get an X-ray. And this is so that I can assess your overall bony health, but also so that I can assess your overall alignment of your cervical spine. So it's more than necessary for me to have X-rays of everybody who walks in the door. Um, I would say that about 100% of my patients who have surgery also get an MRI. The MRI is a more detailed picture of the soft tissues. It shows me exactly where there's compression and where I need to decompress the nerves in the spinal cord while we're in the operating room. The sort of in between one is a CAT scan. Not everybody gets a CAT scan. A CAT scan is a more detailed picture of the bone. And again, I ask patients to get that on a case by case basis. It's more commonly done if you've had previous surgery, and I need to see, did the surgeon before me take out any bone? What does your anatomy look like? Again, because it's all about planning for the operating room. And then lastly, you and we talk about what the plan is. So, are we going to go a non-operative route, or are we going to go an operative route? And I always say I'm a surgeon. I like to operate. I think surgery works when it's properly indicated, but I'm never going to push somebody towards surgery unless I think that you're at a significant risk of having like a neurologic complication without going through surgery. So I'm all in the camp of exhausting all conservative therapy first. So what are those options, right? So with your non-surgical treatment options, really the mainstay is physical therapy, non-steroidal anti-inflammatories, which are your drugs like Advil, Aleve, Motrin, Medrol dose packs, which are steroid anti-inflammatories, heat and cold therapy, and then you have your non-conventional therapies like chiropractic, acupuncture, yoga, things like that. The good news is for patients with cervical radiculopathy, the natural history favors that about 70 to 80% of patients are going to get better with conservative therapy. And our orthopedic literature dates back to the 1960s, and there's data that shows patients do well with conservative therapy. If you still have persistent symptoms, usually after 6 weeks of conservative therapy, we then kind of move into the surgical realm. And the surgical realm, there's a number of procedures, and again, the ones that I recommend are on a patient by patient, case by case basis. But they're also great options. So for the people who have sort of failed conservative treatment, the surgical options, there's an 80 to 90% chance that you're going to experience full relief of your arm pain, with improvements in motor and sensory function. So the outcomes are very good. And again, I don't think we need to get into the exact details of every procedure, but two that I just wanted to highlight were anterior cervical discectomy and fusion and a cervical disc, because or cervical disc replacement, I should say, because I often get questions from patients about what's the difference here. So the anterior cervical discectomy and fusion is pictured here, all the way on the left side of your screen. And this surgery is a very, very effective surgery with excellent outcomes. It has patient-reported outcomes that are very similar to total hip arthroplasties. And total hips are considered to be one of the most successful surgeries in modern medicine, if not the most successful surgery in modern medicine. So, to have a spine surgery that is almost as good as a total hip is pretty phenomenal. The main benefits of doing an ACDF or an anterior cervical discectomy and fusion is that you can address compression in the front of the spine. We can stick spacers in between the vertebrae after we take out the old disc to bring your disc heights back up. And what that does is it provides what we call indirect decompression to your nerves. It takes the pressure off of the nerves in the little holes where they're exiting your spinal cord and going to innervate your arms. With any surgery, there's risks, right? So really the risks of ACDFs are having a potential for a pseudoarthrosis, which is where the bones don't fuse. And really that's your biggest risk, and that's significantly increased in patients who smoke, who have uncontrolled diabetes, or patients who have or who need multi-level fusions. But that being said, the instrumentation has gotten much better. The bone grafting has gotten much better, so our fusion rates are very good. This picture in the center here, this is a cervical disc replacement. So you're not fusing the two segments together. And the idea was that you're maintaining motion in the cervical spine, because you're not fusing them together. And it has very similar indications to an ACDF, plus or minus some pathology. But the cervical disc replacement also works really well. And you might ask yourself, well, you just said that the ACDF was like almost as good as a total hip arthroplasty, so why would you fix something that works so great? And the answer is this. So this picture on the right hand side of your screen, this is what we call adjacent segment disease. So after a segment is fused, you can get accelerated arthritis at the levels above or the levels below the fusion. And so us as orthopedic surgeons tried to think of a way to decrease the rate of adjacent segment disease, although it's about 2.9% per year after a fusion. So it's small, but it's not zero and it's not insignificant. And when you extrapolate that out to 10 years, it becomes a real issue for patients. So the idea was we're going to invent something that's motion sparing and hopefully reduce the rate of adjacent segment disease. So how do you get to that surgical option, right? Well, this is sort of the algorithm. You need to have pain, weakness, or numbness in your arms. You need to have failed 6 weeks of non-operative treatment. Again, that 6 weeks is what our literature shows us that patients will either get better or they won't. And it's also sort of become a cutoff for insurance companies in terms of them approving your surgery. You then have to have corresponding imaging, right? So as I mentioned, everybody gets an X-ray, pretty much everybody gets an MRI, plus or minus people getting CAT scans. So, if you have a herniation on the right side, but all of your pain is on the left side, then we have to stop and think, well, what's causing that pain? Because your imaging is not matching your clinical symptoms. So having corresponding imaging is key. And then the last thing is getting medical clearance from your doctor. And if you have any other significant medical issues like cardiac problems, perhaps having a cardiologist see you. And then you and I have to sit down and we have to talk about the risks of surgery. And that's a really important part of a pre-op discussion, is understanding the risks and helping you manage the expectations post-operatively. So just to sort of finish up, you know, as I was finishing my fellowship year, I knew I was coming into a new leadership role as an attending spine surgeon. So these are the last two books that I read. The one is called Extreme Ownership. The other one is The Dichotomy of Leadership. And they were written by two former Navy SEALs, Jocko Willink and Leif Babin. And the ideas behind the book is that these guys took their military experience and their leadership principles and they apply it to real world business, medicine. And so, a lot of the principles that they talked about in these books have been applicable as I moved into the role of an attending. So, what I want my patients to know, first and foremost, is that you and I are on the same team. So I want the same thing as you. I want you to get better. I want you to have a good outcome, and I want you to be able to live your life pain free and do the things that you enjoy. So the question is, how do we get to that point, right? So the first thing is we have to plan together. So planning involves talking about non-operative treatments, operative treatments, our expectations after surgery, and the risks of surgery, right? And then the second line here, or the third line, I should say, this one's really on me. So, I always joke that surgeons aren't necessarily known for having small egos. And so my promise to my patients is that I'm not going to be cocky, but I'll be confident in the decisions that I make in the operating room for you, and even in the office for you. And then this why was a big portion or a big take home point from these two books. And the author said that your team has to know why you're doing something. Why do you have these certain objectives? Because if you don't understand why, then you can't really buy in to what you're doing. So, I want my patients to know why I'm recommending non-operative treatment, why I'm recommending surgery, why I did certain things in the operating room. And I think when you understand why, that eliminates a lot of confusion, especially between the surgeon and the patient. Again, I'd just like to thank you guys all for your time. And I think Savannah was going to pop back on, and if there's any questions, I'm happy to answer them, or I can pull up the chat.
Yes, thank you so much, Dr. Buttle. So if anybody has any questions, you can feel free to unmute your mic right now and ask. Again, if you don't feel comfortable doing that, feel free to type in the chat. I'll wait a couple seconds just in case anybody's typing.
Will there be a recording that you can view of this? I never got the email to get on, so I missed most of it. And this doctor was like fantastic. I would love to see the whole presentation.
Yes, absolutely. So it was recorded, and we're going to be sending it to your emails. If you don't see it, check your spam folder. I know sometimes, unfortunately, our emails do go to people's spam folders. If you also check our social media, we do post the links on there when we're about to go live. So I'm so sorry that you weren't able to hop on, but we will absolutely make sure you get this recording.
Thank you so much. And the doctor was great. I enjoyed the little bit I got to see. I really enjoyed. Thank you.
Yeah, I appreciate it. I saw that there was one question. So, what's involved in injections? So, injections, I personally don't do the injections. We have a great team of pain management doctors who do the injections at Seaview, but the injection, there's a couple components to it. So what is the injection, right? So the injection is commonly a mixture of lidocaine, which is a local anesthetic, and a steroid. So the steroid is meant to almost be like a sniper shot of anti-inflammatories into a targeted area. So if you have a compressed nerve, a lot of times there's inflammation there. So if you hit it with a steroid, it can help calm the inflammation down and it can help alleviate your symptoms. In terms of where the injections are placed, I always write in my note after I see you where I think the compression might be coming from, but I also do, leave it up to the discretion of the pain management doctor where he or she thinks it should best be put. And there's a couple of different areas. You can have like epidural injections, you can have transforaminal injections. They can be done in your low back, they can be done in your thoracic spine, they can be done in your cervical spine. So there's lots of different areas. The key with injections is that they serve two purposes. They can be diagnostic and they can be therapeutic. So diagnostic in the sense that if you if you get an injection and your arm pain goes away even for a day, like you're like, wow, I feel great. I don't have any pain at all. And then it comes back the next day and you're like, well, that stinks. Yes, it's upsetting because you didn't get better, but it also tells me as the surgeon that that is the area that is bothering you. So if I target that area in surgery, then I can predictably or more predictably alleviate your pain. Um, or the better solution is that it's therapeutic and it calms down the inflammation enough that you don't have any pain. And honestly, no one cares if they have arthritis as long as they don't have pain. Arthritis is not something that's gonna, necessarily kill you. So you can have arthritis. People only care about it when it becomes symptomatic. And then the other question is there a better way to sleep with a pinched nerve in the neck? Um, So I think the political answer is sleep however you can get comfortable. Um, uh, you know, a lot of times people, not that I think sleeping like this is comfortable, but when you bring your arm up, you're actually taking pressure off of your nerves in your neck. So a lot of times I'll ask patients, bring your arm up. Does that make your pain better? And most of the time patients will say yes. That being said, if I'll also take my hand and stick it on heads and push down at that side, and that can make it worse. So I would probably avoid sleeping with your head tilted like this because that's going to compress your nerves more. If you can bring your arm up, that sometimes helps, but it's really just a matter of finding a comfortable position, but definitely avoiding like side bending, what we call your neck, that or whichever way, whichever arm is bothering you or whichever side you're feeling the pain. Third question is how do you determine after getting injection when surgery is necessary? So that question is really, up to the patient, right? So, if you get an injection and like I said, if you get 100% relief and you have no pain, then surgery is not necessary. If you get only 30% relief of pain, or you get 100% relief of pain, but then it comes back 2 days later, then surgery is a good option for you. That being said, I tell patients that surgery is a firm decision, right? You cannot undo it. So my advice to patients is if your pain is like annoying or you can get by with taking over the counters every once in a while, um, don't have surgery. Unless you're developing weakness or profound numbness, don't have surgery. If your pain is so severe that you can't do things with your friends or your family, then surgery is a good option for you. I think at that point it's a quality of life thing, and that should be your tipping point. But I've always gone through my training as being in the camp of offering you the options and letting you and your family members decide. Because I don't ever want to push someone towards having surgery. I want you to be fully on board with having surgery. And again, if I think if there's an inherent risk of you having permanent damage to your nerves by not getting surgery, am I going to tell you? Yes, but I'm never going to force anybody to have surgery. Um, will PRP work for neck pain? So I've gotten this question before, and I'm not aware of any studies that show PRP will work for neck pain. The other difficult thing with PRP is that it's really expensive, and insurance companies oftentimes don't pay for it. I think I personally have never seen any of my attendings um, uh, inject people with PRP in their neck. I've seen it done in knees and hips and other major joints, but I've never seen it in the neck. Someone else was just asking about the office, and then what is the percentage of success did you see in your practice? Um, I guess what are we specifically talking about there from? Oh, for neck pain. So, you know, neck pain is, again, it's hard to say, right? Because that I think that's a my view of my success rate is skewed, right? Because if someone's not necessarily happy with their outcome, they may not come back and see me, but I don't necessarily know that, right? So in my mind, they had a good outcome, but maybe they're seeing, another surgeon for a second opinion. But, I go by what our orthopedic literature tells us. And our orthopedic literature tells us that people who have primarily neck pain or primarily low back pain, a majority of patients get significantly better with focused physical therapy, anti-inflammatories, and conservative treatment. There is strong evidence that shows that people, or the horror stories, if you will, of spine surgery, are people who get, big surgeries, particularly fusions for strictly neck pain and strictly low back pain. They don't do well. Their outcomes are unpredictable, or they get worse. I think a more realistic expectation, if you're asking about neck pain, is someone who comes in, with myelopathy or radiculopathy, and they also have a component of neck pain. I tell patients that there's about a 50% chance your neck pain is going to get better, and 50% chance that your neck pain is probably going to stay the same. Next question is, I've had a pinched nerve in my neck since mid-August. Had an MRI done. It showed herniation at 6'7". I've done PT, and now I'm going to chiropractic doing decompression. My index finger is still numb. Will the numbness go away in time? If you've had it since mid-August and you've done 6 weeks of physical therapy and you're showing that you have a herniation, usually once you get outside that 6 weeks, it's unlikely that the body's going to reabsorb the disc on its own. So at that point, I would either recommend having a shot, or if you're really having persistent numbness, that would be an indication to do surgery. The order of events is usually pain, weakness, numbness. So people have pain first, then weakness, then numbness. So by the time you have numbness, your nerve may have been compressed for a while. So weakness and numbness are less predictable in the post-operative period in terms of them fully coming back. Pain, 90% of people are going to have full resolution of their pain. The numbness and the weakness take some time to come back, and often they come back with another course of therapy, strengthening and doing like resensitization and of your finger and things like that.
So I actually have a question that was called in from a patient who was unable to attend today, but still wanted to get some advice. So
Mhm.
he had had surgery not too long ago, and overall everything went well, and he's pretty happy. But he's still finding that he is struggling with tension headaches and occasional numbness in his hands and fingers locking up. So he just wanted to get some advice on that.
So he had surgery and he's still having some numbness and tension headaches. So again, sort of what I kind of like just alluded to, right? So the numbness is sometimes not as predictable as pain. So, hopefully his surgeon told him prior to that your numbness may not get fully better, so that he was, can expect that in a post-operative period. Um, the tension headaches are a little different. So, there's a bunch of different etiologies that can cause a tension headache. Sometimes people get a little bit of a headache because if you think about it, when you stick spacers in between, you guys can all still see my presentation, right?
Yep, it's still up.
Okay. So if you stick, I know this is the picture of adjacent segment disease, right? But if I stick a spacer in here, I'm basically making the disc height taller. And if you do that over enough levels, or you make the space so big, it stretches out the muscles in the back of your neck, and people can get some pretty significant pain from that. Usually it resolves over time. So, things like muscle relaxers and starting up PT again can help with that. But that's often what the source of like a headache can be. And then again, if it really doesn't go away, then I would recommend that they see a neurologist because that's sort of the neurologist's area of expertise is headaches.
Thank you. So, does anybody else have any final questions before we jump off for the night? You can go ahead and type in the chat, or again, feel free to unmute your mic. I'll again just wait a couple seconds for people to type. All right, so it looks like, oh, we got a couple. What is the office? Oh, so our number, if you would like to book an appointment, you can do so on our website, seaviewortho.com. We actually have a new virtual assistant in the bottom right corner. You can book an appointment online, or if you prefer to call, you can call 732-660-6200. But I believe we just got one more question in the chat.
Yeah, so the question is, can damaged nerves in the neck regenerate? Um, the short answer is, I mean, I guess it depends on what you mean by regenerate, right? So it again, if you're asking, can I get rid of your pain from a compressed nerve? Yes. The key with nerves is taking the pressure off of them. Nerves really, really do not like to be compressed. And if you get compression over a significant period of time, then that's when you start developing numbness and weakness. And once you take the pressure off of the nerve, the other thing I tell patients, in the post-op period is that you really have to focus on eating well, right? So you got to have a good diet, high protein. One of my, lifelong mentors used to tell us that you got to tell the patients they got to get gas in the tank, right? So you have to make sure that your body has a high protein diet so that you can not only heal your surgical incision, but hopefully start healing your nerves. Um, you know, if I'm sure people have heard of people having devastating spinal cord injuries, right? And there's been a lot of advancements in spinal cord injury like management. But it always comes down to getting the pressure off of the spinal cord as fast as possible. And so, when we have a patient who comes in with a spinal cord injury, that's our main objective, right? So, no one can really tell you at what point the nerve is just gonna say, you know what, like I'm not. It's gonna be numb. Like it's not coming back. I don't think anybody can give you that answer. There are certain medications that help, protect the sheath around the nerve, such as gabapentin. So a lot of times, if patients have numbness or weakness, when I see them in the office, I'll often prescribe them gabapentin to help protect the nerves until they can either get a shot or I can get them in the operating room, and then we slowly taper them off. Um, then another question was, will traction help with this? So traction's a funny thing. So, I get this question a lot, and it's sort of I don't have a negative view of traction. I think it provides some temporary relief, right? So you put yourself in traction, you get relief of your arm pain. But the unfortunate thing about traction is as soon as you take it off, gravity is going to take back over, and your head's going to push back down, or your low back's going to push back down, and the pain's going to come right back. So no matter how much you stretch yourself with traction, gravity is always going to win. So if you have compression from the disc heights collapsing, you might get some temporary relief, but it's going to come back.
All right, so it looks like that is all of the time that we have for tonight. If anybody does have any unanswered questions or concerns, Dr. Buttle is currently accepting new patients. As I mentioned before, he sees patients at all 6 of our Seaview offices. So that is Ocean, Brick, Barnegat, Homedale, Monroe, and Freehold. If you want to book an appointment, again, you can go to our website, seaviewortho.com, and you can have our new little virtual assistant in the bottom right corner help you out, or you can call us at 732-660-6200. And just in case you hopped on a little late and missed my intro, we do these virtual education seminars every other month. So information for that can be found on our website under the About tab or in the news section of our homepage. The best way to stay up to date on all things Seaview Ortho is going to be our social media platforms. So we are at Seaview Ortho on Facebook, Instagram, TikTok, and LinkedIn. We also have a podcast that you can find on our website, Apple, Spotify, and Amazon podcasts by looking up the Seaview Ortho podcast. And of course, you can sign up for our newsletter at cvortho.com. We send those out twice a month, and all information on upcoming events and just educational things will be sent to your email as well. I just want to throw out there that we also have our Fall Family Festival coming up for anybody who is in the Homedale area. On Saturday, November 4th, we are having a fun afternoon full of live music, food trucks, games, vendors. It's going to be a really exciting day. So we do hope that if some of you are in the area, you can join us for that. Again, that's Saturday, November 4th from 12 to 3. And just one more time, this presentation was recorded, so it'll be sent to your emails tomorrow morning. Feel free to share it with anybody you know, or if you just want to rewatch it to refresh your memory. So thank you again to Dr. Buttle for giving us your time tonight, and thank you to everybody who logged in to watch. We hope you join us for another virtual seminar soon, and enjoy the rest of your night.
Yep. Thanks again, everyone. I appreciate your time. And just real quick, yes, the McKenzie method of physical therapy is helpful. Really, any low back exercises or stretching will be helpful. But I think there's a benefit of having a PT, guide you through those exercises. The PTs in this area, particularly the ones we have at Seaview, are very knowledgeable and very helpful. So at least going a couple sessions and learning it from, they're the experts in that. So, I would learn from them too. But thanks again, everyone. Enjoy the rest of your night.
Thank you, everyone. Good night.